Welcome back to the Dr. Noel program. We are continuing our talk with Professor Dennis, who is the Professor of Medicine at University of Western Sydney and the Chief Editor of Heart, Lung and Circulation Journal. And Professor Dennis, thanks for the explanation of the risk factors. However, I would like to further ask what constitutes a higher risk categories in some patients and what induces those categories?
The highest risk patients are those who already have blood vessel disease somewhere, whether it would be in the heart or the blood vessels to the brain or in the aorta that goes down to the rest of the body or in the arms or legs. In addition, people who have kidney disease, diabetes, thyroid disorders, high cholesterol on a hereditary basis, or have an indigenous background have a much higher risk than average of blood vessel problems.
Thanks, Professor, for the description. And what's the natural history of cardiovascular disease?
The natural history of coronary artery disease involving the blood vessels to the heart is very variable. These atheromatous plaques of fat, can be asymptomatic, not cause any symptoms for many years. They can occur slowly and not cause any significant issues until they narrow the area of the blood vessel by about 70%. At that stage, there might be enough blood going to the heart at rest, so there'll be no symptoms. But as soon as the person tries to exercise, there is a restriction of flow and there is not enough to cope with exercise. So some chest pain or other symptom of coronary heart disease occurs. At about this time as well, some people get into problems with the plaque being unstable. The plaque can lift, the plaque can rupture, and as we've mentioned before, if the fat comes in contact with the bloodstream, then a clot can occur. When this clot blocks off the artery, there is a heart attack. The severity of the heart attack depends on how long that blood vessel is blocked from that clot. So there's a progression from no symptoms to some symptoms that are predictable, that's a stable period, and then there can be a period of instability.
Thanks, Professor. Can you tell us about the symptoms of heart disease and the symptoms of the vascular disease?
There are 4 major symptoms related to heart disease. One is pain, and I'll elaborate on that a little later. Another one is shortness of breath. Another is palpitations. And the other grouping is dizziness or actually blacking out. Now, a very common symptom related to the heart is pain. This can be in the chest or the arms, less commonly in the jaw, and sometimes even in the back. Pain related to not enough blood supply to the heart is classically poorly localized and suffocating. Some people will describe it as an elephant foot sitting on their chest. It is often precipitated by exertion or emotional stress and can be associated with nausea and sweating. Pain due to not enough blood supply to the heart can be quickly relieved by a medicine taken under the tongue called a nitrate, which can dilate or open up blood vessels and help relieve the symptoms. And classically, with pain related to narrowing of the arteries to the heart, this relief occurs within a few minutes. There are some other causes of chest pain that can be confused with heart-related pain, and they are more likely to occur from the esophagus, which is a swallowing tube that runs behind the heart going down to the stomach. That can either spasm or have irritation of its lining. Other pains can be from the chest wall, musculoskeletal pains. There can be pains related to the lining of the heart being inflamed or irritated, and similarly pains related to the lining of the lungs being inflamed or irritated. Rarely you can get a similar pain from the big blood vessel, the aorta, splitting. Pains that are unlikely to be from narrowing of the arteries to the heart can be pains that are worse on breathing in or moving, changing position, pains that can be localised with the tip of a finger, pains that can be reproduced by palpating or prodding the chest wall, and pains that might occur in the abdomen and radiate down to the legs. They're unlikely to be from the heart.
From the heart. Mm. So, because sometimes people will just confuse that to gastro or renal colic, and they don't know what's causing it. So there might be a cause of or coming from heart attacks or other sort of diseases.
No, there can sometimes be some blood vessel problems that cause pain in the lower abdomen and in the legs, but from the heart itself, it is rarely that it gets below just underneath the diaphragm.
Okay, so just for when it's heart related, it's from diaphragm and up.
Yes.
So, Professor, if a person has a chest pain and some of the symptoms you explained, what are they supposed to be doing?
If chest pain persists despite simple measures such as stopping the activity that brought it on or taking a nitrate under the tongue, then medical attention must be sought urgently. The best thing is to get an early electrocardiogram. The best thing is to get this by calling the ambulance and getting into hospital. The ECG or electrocardiogram is an electrical recording taken from wires placed in the limbs and across the chest wall in a standard fashion, and it often gives a clue as to whether someone is getting pain from the heart or not, and in some instances will tell you straight away that there's a heart attack present. In the ambulance, the treatment starts with aspirin, oxygen, and some more nitrates taken under the tongue. Many ambulances nowadays have ECG capability in the ambulance, but in any case, once the person gets to hospital, an ECG can be performed and various blood tests. It is important to do multiple ECGs and, if necessary, multiple blood tests to try to confirm the diagnosis. Sometimes the diagnosis of a heart attack is obvious, sometimes it isn't, and sometimes the chest pain is due to something else. And there might have to be a different group of non-invasive and invasive investigations. But if there is a heart attack confirmed on the ECG, then it is important to get the artery opened as quickly as possible, as time is muscle. The arteries to the heart muscle can be opened by clot-dissolving agents or by direct aspiration of the clot at the time of cardiac catheterization, putting a tube up to the artery. The clot can be sucked out and a balloon and stent can be put down to open up the artery and keep it open at the site of the heart attack. If this can be done within 3 hours of the onset of pain, then there will not be much damage done as a result of the heart attack. Between 3 and 12 hours there will be significant benefit as well, but after 12 hours there's less benefit. So the moral of this story is if there's persistent chest pain, then get to have an ECG and get to medical help.
Thank you, Professor. It's a very important subject which we are talking about, and thank you very much for your explanation and the descriptions. And due to time restrictions, we are not able to ask further questions because that will take us much longer time. So if you can be generous with us and maybe grant us another episode, and we would like to see you again.
I shall look forward to it.
Thank you very much for listening to this episode tonight, and we will come back to you with some further explanation and more description of heart and cardiovascular disease. Thank you.